talk. I think we have Dr. Somnath Chakraborty, who is from Veterinary Institute of Bengal, Siliguri. I think he's going to present a challenging case presentation. Over to you, Somnath.
Good morning, sir. Good morning, everyone. Is my slide visible?
Yeah, I can go to full screen mode.
Yes. So, good morning. So, my case was a 72-year-old female. She's a known hypertensive since 10 years. She presented to us with complaints of distorted vision in her left eye since 3 months. She also gave history of having received 3 ranibizumab injections in the same eye. Last injection was 5 months back. So her right eye evaluation was within, everything was within normal limits. In her left eye, her best corrected visual acuity was 624. And fundal evaluation showed there was a large full thickness macular hole with an underlying pigment epithelial detachment. So the OCT confirmed the presence of a large macular hole with an underlying pigment epithelial detachment and an overlying operculum. So what could have happened in our case? So there are till date 6 cases of reported cases of macular hole formation in eyes undergoing anti-VEGF therapy. The hypothesis is that probably multiple anti-VEGF injections alter the vitreous gel and thus induces a vitreous collapse. And if there is an incomplete PVD, then there is an increased vitreomacular traction on the pathology, on the diseased macula, and this can lead to formation of a hole. So now that we have a macular hole, which probably has been formed secondary to the multiple anti-VEGF injections, how do we go managing it? So can we just manage it medically? Because there are reports of successful closure of macular holes in situations where there is an associated PED after anti-VEGF injections to treat the PED. However, in all those reports, the macular holes were small to medium in size, that is less than 400 micron, and there was persistent vitreomacular traction. In our case, however, there was already vitreomacular separation and the hole was large. It was more than 400 micron. Therefore, we felt that it would not be probably right to go with more anti-VEGF therapy and trying to resolve this PED, and rather it will be better if we go and treat this macular hole. So we know the treatment of macular hole is based on the aperture size of the hole. And based on the aperture size, the holes can be further subclassified as small, medium, or large. So in large macular holes, as was in our case, the treatment option is surgery. Vitrectomy alone can probably have a low success rate, and therefore it is suggested that we do ILM peeling along with the vitrectomy. So that's what we planned. So this is the video of the case. So we used Alcon's 27 gauge system to manage this surgery. So after making the 3 ports, we proceeded to do a central vitrectomy. Once the central vitreous had been removed, we used triamcinolone acetonide to stain the posterior hyaloid. And then with the 27 gauge cutter in the suction mode, we gently induced a complete PVD. We know that Constellation's IOP compensation mechanism really makes this very easy to induce PVD safely even with high suction. Once the vitreous had been completely removed, we stained the internal limiting membrane with a brilliant blue dye and created a temporal flap, a temporal inverted ILM flap. And then once that large temporal inverted ILM flap had been created, we covered the hole with the same. Once the flap had been safely secured over the macular hole, we did multiple fluid air exchange to ensure that there is no fluid left inside the eye, and then close the case with a SF6 injection. So 1 month post-surgery, patient felt better. There was a 1-line visual acuity improvement. The PED was still could be made out. The hole appeared to have closed, but with defect. So this was her OCT picture. The PED height appeared less. The ILM flap could still be seen, and there was type 2 closure. But by 4 months, the patient came back and she was much more happy by then. And this time, the foveal architecture appeared normal. The OCT also confirmed that there was complete restoration of the foveal contour with restoration of the outer retinal layers as well. And there was further reduction in the height of the PED. So why we chose to, so if you see with PPV and the temporal ILM, inverted ILM flap technique, we could successfully close the hole with 2 lines improvement in vision. And also interestingly, we saw some resolution of the PED also. So why we chose 27 gauge, as already is shown so beautifully by Dr. Gandhi, that we know that narrower the mouth of the cutter, or in other words, smaller the gauge of the instruments, the smaller of the sphere of influence and greater the dissection precision. So with 27 gauge, since the sphere of influence is the least, so this is one of the safest way to do precise surgery, which was very important for us because the macula had dual pathologies here. Also, we know that higher the cut rate, lesser the traction on both vitreous and retina, again, something that makes the surgery safer. And Alcon's advanced ultra-wide bevel cutter, as we have already said, allows us 10,000 cuts per minute, making the surgery much more safe and controlled. So regarding ILM flap, so we all agree that large macular holes require ILM peeling along with vitrectomy, but the anatomical success rate with conventional ILM peeling is low, varying from 40 to 80%. With inverted ILM flap techniques, the anatomical success rate is higher and the functional recovery has been seen to be faster. But we did not do a conventional multiple radial ILM flaps, which are then tucked into the macula, but we preferred the temporal inverted ILM flap. Now, this was first described by Michael Wiska, and we know that it is as effective as the classical ILM flap technique for repair of large macular holes. Moreover, the benefit of doing this is that you have to do peeling over a smaller area, which means it minimizes surgical trauma, something that was very important for us in this case, as there was not only a hole, but an underlying PED. So we really wanted to be very safe. Moreover, we did not tuck the ILM flap inside the hole because of late multiple studies have shown better anatomical outcomes and quicker recovery when we cover the hole with the flap rather than filling or plugging it. One of the interesting observations in our case was that there was a gradual anatomic restoration. This has been reported with ILM flaps in previous studies also, because because it has been seen that ILM flaps help reintegration of outer retinal layers, and this can occur slowly but steadily even over 12 months. A recent study even suggests that temporal flap technique particularly probably enhances this natural course of macular hole closure. So the take-home points from my case was that it was a case of a large macular hole associated with a PED. We believe the hole was a complication of multiple anti-VEGF injections received before. We could successfully close the hole with 27 gauge vitrectomy and temporal inverted ILM flap. And we believe that with these recent advances in vitreoretinal surgical techniques, large macular holes, even when associated with rare pathologies, can be managed successfully. Thank you.